know the best guy to help us to answer this question. He's just sitting there, this smart guy there, Dr. Islam Anan, who is the CEO, ExCite, Research Lecturer of Health Policy and Health Economics, ASU and MAU, Egypt. Please welcome Dr. Islam Anan.
So thank you, Dr. Ahmed, for the introduction and for the moderation. Thank you for the panel, for the interesting storyline that I will be continuing on it. And you made my life as well very easy. And thanks for the South German Hospital for the invitation and for the organization of this marvelous event. So actually, I have 10 minutes to tell you what will be the plan for the next 10 years. So excuse that I will be a little bit fast. I will be actually moving from the national level to Africa level and then to hospital level, because applying health policy, it can be on a hospital level. We're going to discuss, okay, if medical coding is important, and as Dr. Hussein mentioned, and augmented by Dr. Ihab and Dr. Ahmed, it's of greater value, it is cost effective, it is cost beneficial, so why we don't have medical coding? So why we are not implementing medical coding in all our public hospitals and private hospitals? And I was lucky to be actually working at the African continent and sub-Saharan and the rest of African countries. And some countries got very good case studies on applying ICD-10. Others are still struggling in migration. So we're going to go through before and after, how to implement the gaps, opportunities, and the health policy required if you would like to implement the revenue cycle management of medical coding. So we are in a migration phase here in Egypt. We do have a lot of entities working together, and these are all public actually entities, and we are not even listing the private entities or the other ministries, because we know that we do have a reallocation and allocated budget from the Ministry of Finance to each ministry for healthcare. So the Ministry of Civil Aviation, for example, they got an allocated budget for healthcare. The Ministry of Petrol and Gas, they got an allocated budget for healthcare. So we do have, I guess, I've been working in 35 countries. This is the most complex with the largest amount of entities that you can actually flip through. And imagine if you would like to take a file from an entity to another entity just to register one medication, registering at the EDA, then going to the GHA, then coming back to the Ministry of Health for demand and supply, going for the UPA for reimbursement, and then taking your money from the pharmaceutical company, but the hospital must be accredited by the GAHAR. So imagine the motion and imagine the movement of files if it's manual. Imagine if you are a pharmaceutical company, medical supplies company, just taking all these documents in a paper, you know, this gray dossier, in a gray paper dossier, and moving from a ministry to another. So it's not only medical coding, it's digitization. So we definitely need it, but we definitely need it done in a right way. And all the time when you open any news channel talking about sustainability development goals, أهداف التنمية المستدامة for Egypt 2030, you will hear 4 jargons. حوكمة, هيكلة, ميكنة, رقمنة, right? And I always say حوكمة بدون رقمنة زي هيكلة بدون ميكنة. Okay? So what does it mean? So Hawkama is a governance. We are actually splitting entities because of specialization. That's why we have EDA, we have GAHAR, we have GHA, we have the UHIA. We have different entities. There is no one umbrella like MOH like before, and we do have several service providers and service payers. But can we continue using paper? No, because that's why we need digitization. If we're still using paper and we don't have medical coding in hospitals, how I will be able to allocate budget from the hospitals to the UPA, Unified Purchase Authority, to make the value equation Dr. Hussein mentioned, and to actually make the supply and demand curve for the UPA to get the supplies back to the hospital. And we've been struggling a lot between governmental entities just to, this simple equation, value, costs, and outcome. It's very simple in writing. It took years just to establish it in one disease area. And then structuring, you need a good structuring for the all entities to be able to work together, and finally automation. If you cannot automate the process, you're not going to be able to make medical coding, you're not going to be able to generate revenue cycle management, automated process. So I remember when we started the UHIA, Ta'min al-Sihha al-Shamil, and Vodafone Health presented that they would like Egypt to follow the Lorenzo information hub system, which is applied by the NHS. It's a very complicated system. Patient go to a kiosk, and from the kiosk, there is no paper. He will just register, see the primary care. It go to the medical coding process, to go to the lab, to the pharmacy, then the reports, then he will dispense the medications. We do have a medical records, we do have an output. So it summarizes most of Dr. Hussein, Dr. Ehab, and Dr. Ahmed were saying in one system. But can we achieve it, and when can we achieve it? Because it's very beneficial, it's very cost effective, but when can we actually achieve a system like the complete integrated HIS like Lorenzo, for example? So we have two pillars. We need to ensure access and we need to ensure reach. The steps of revenue cycle management of access is very clear and illustrated marvelously by Dr. Ahmed in the third presentation. So access, it means I need to make sure that all the resources are there. I have the manpower resources, I have the IT processes illustrated by Dr. Ehab, I have what it takes in terms of actually costing and value generation illustrated by Dr. Hussein. These are all access that I need to put in hospitals and put in governments, entities, to make sure that I can implement. Reach is a total different story because I need people to utilize it. Because I remember working on the ICD-10 with the cancer registry in Egypt 6 years ago. We do have a marvelous set. WHO got a big fund, World Bank was in, ICD-10 was applied, and we've done the analysis, and most of the codes were actually, even for cancer types, NOS. You know the NOS code? Not specified. The oncologists were actually putting 60% of the codes as NOS. So you are telling me that the oncologist doesn't know that cancer is actually located in the right breast or the left breast? It was just easier for the medical coders and registrar to just press 99, which is NOS. So REACH got training, and most importantly, what's in it for us? Because every hospital, every entity, every government will just say, what's in it for me to make the coding, the extra work? If we are actually looking for physicians to do it, they are overloaded. If we are looking at the hospital without incentivizing them to do it, they are not going to do it. Or they will just do it in a NOS 99 codes. So we need incentive. We need to incentivize healthcare providers to initiate coding processes. Because we need the data. You know, this is a very famous hierarchy of the IKW pyramid. It's a very famous one. You get the data, which is raw medical codes. You put some meaning on it, so 99 or NOS, it means not specified, so it is an information, just putting a meaning. And if you got the knowledge of the healthcare system, you got a context, and finally, it will enable you to have an informed decision, which is wisdom. You cannot take decisions unless you got data. In the Canadian system, the minister cannot take any decision unless he got data, information, knowledge, and wisdom, and just gonna say, I will actually decrease manpower or increase manpower because the data is saying, or I'll tell you what, in clinics, 190, what does it mean 190? It means nothing, right? Data means nothing on its own. Is it high or low? We don't know. If I'm telling you that 190 is a systolic blood pressure, so it is an information. As a physician, do you know if this is a high systolic or a low one? High. So it's knowledge. Should we manage this patient? This is wisdom. Imagine that any patient going to be in the clinic without actually measuring blood pressure, you are giving him hypertensive agent. Completely wrong, right? And it is completely wrong in medical coding. It is completely wrong in the RQW, because actually sometimes you need to, is it like this? Yeah. Because sometimes you will find this pyramid actually flipped. You are taking a lot of decisions without data. You are taking major multi-million-dollar decisions without information. Just because your gut is saying that I feel this is going to be a good project, I feel this is going to be a good place to put your hospital in. So, moving faster, what we need to achieve and what we need to do in order to have good revenue cycle management and good, actually, coding is the RPO, which is a nice model. Our eminent speakers were actually revolving around the model. We need to have resources, human resources, which is us, trained, good competence, good knowledge of medical coding. We need to have, most importantly, money. And I remember yesterday in the presentation of Dr. Hani Raugi, if you were there, he was saying that Mayo Clinic spent $1 billion, you heard it right, billion US dollars to apply the full automated integrated health coding. So why? Because it's cost effective, it will generate profit. And finally, you need the system, the IT system. You need the processes, illustrated by Dr. Ihab and Dr. Hussein, a lot of processes, and you need to track outcomes. And tracking outcomes, as Dr. Ahmad mentioned, will let you not only have a good system of revenue and you know the claims and you are actually decreasing waste, it will enable you to have good registries and data management, a good quality of life surveys. We don't have enough quality of life or real world evidence studies here. We need prescription algorithm. We need interchangeability data. We are using generics in a messy way. You know that you cannot switch from a generic of a product to another generic of a product unless you got an interchangeability. This is an interchangeability. Unless you got an interchangeability data. From where you can get an interchangeability? From tables. Tables coming from registries. Finally, health economics data. So, where are we? So countries in Africa are actually classified in migration from paper-based to fully automated medical coding, HIS, Health Information System, based on a plan. And that's the plan of part of the plan of Africa to some countries and emerging market countries. And as you can see, we got 5 stages. If you'd like to migrate, we got 5 stages. You need first to use conventional paper. Are we using conventional paper? Sometimes, yes, sometimes no. Still, we got some hospitals, and I can name some, they are not even using paper. Patients are going back home with their files. Then stage 2, if you are doing so, you need to optimize it. 3 is to migrate. 4 is to have a system, IT system, and 5 is the fully comprehensive integrated system. Where are we? As you can see here, you can say our score and your hospital score based on this chart. But you can see, for example, that Zambia is currently going stage 4, which is a very nice example. Kenya as well. Kenya is illustrated in stage 1, but when I visited the MOH in Kenya, they're actually now migrated. They are going to stage 3 as well. So we need this plan, and this plan in Egypt was put for 2030, and this is my final case because people are saying we're going to spend too much money on that, but it's very beneficial. This is from a hospital level. That's Samsung Medical City. You know, Samsung in Korea is not just a company. It's a medical. It's a big city. The medical cities are migrated from paper-based to complete EMR in around 6 years, and each $1 spent on migration got a benefit of 1.23. So they are actually gaining profit. They are gaining profit. But it's not from the first year. As you can see, 2006, 7, 8, 9, 10, all of these were migration years. 11, starting 2012, revenues were generated. Profit, real money, profit to the hospital because of applying medical coding. If you are moving too fast, you will be actually like Brazil. Brazil moved in this plan too fast that they got the system access in and zero reach. People were not convinced. So again, I repeat, we need to convince people that we need medical coding and it is important. Thank you.